Hi, I'm Dr. Michael Moore. I do a lot of the complex reproductive surgeries for conceptions. I came to Denver in the mid-1980s to do a reproductive fellowship. I was actually with conceptions for several years during the 90s. I just loved minimally invasive surgery. I did it before they called it minimally invasive surgery. I wanted to immerse myself in these procedures that, instead of opening the abdomen, causing a lot of pain, prolonging recovery, we know that minimally invasive surgery is less painful, the recovery is faster, and in many instances the outcomes are better because there's less adhesion formation. Because we're using a scope with magnification, you actually can see much better when you're using the scope instead of with an open abdominal operation. So there's various uterine disorders that require surgical attention. Polyps are tumors of the uterine lining. Fibroids are tumors of the uterine muscle. The uterus is a big muscle. Inside is the cavity lined with glandular tissue where the embryo implants. So polyps, we don't know why women get them. They are of the uterine lining origin. They project into the cavity, and we think that they may interfere with implantation. So we generally recommend removing them. Now, polyps are easy to remove. You go through the cervix, you use a tiny scope to remove the polyps. There are ways to remove the polyps that are bigger with electrosurgical energy. Smaller polyps can, sometimes just be removed by scraping them out or taking them out with a pair of forceps. And by removing the polyp, that will improve the chances for conceiving. Fibroid tumors, so tumors of the uterine muscle, those fibroid tumors, when they grow into the cavity and distort the cavity, have been shown to definitely reduce the chances of successful implantation. So fibroids that grow into the cavity are called submucosal fibroids. And there are fibroids that are completely within the cavity, partially within the cavity, and if they're not too large, I can use a scope, go through the cervix with that scope, and remove that fibroid. The uterus needs a little time to heal, and once it's healed, then the chances for pregnancy are much better. Polyps heal a little bit faster because they're not as deep. There's not as much healing that needs to occur. So generally about 6 weeks after the polyps removed, the woman can try and conceive. Other uterine issues that affect pregnancy are uterine septums. Without getting into too much embryology, the uterus is formed by the fusion of two tubules of tissue. And when that fusion is incomplete, there will be a septum, a projection down into the cavity. And the concern is that it may cause an increased risk for miscarriage. It may cause premature labor. It's a little worrisome. And we know that if you fix the septum, it may increase the chances of a successful pregnancy when a woman has had multiple miscarriages. But why wait until a woman's had a miscarriage? If she has a septum, perhaps it's the better thing to fix it first as opposed to waiting until she's had a miscarriage. Fixing a septum surgically is actually not a very difficult operation. Because those tissues were supposed to come apart in the first place. And so when I go in to divide the septum, it's very easy to see where it is and find the avascular plane and then divide that until it looks like a normal triangular cavity. Once I repair the septum, I need to put a balloon catheter inside the cavity afterwards to hold those two walls apart so they won't stick back together again. That balloon's in for a few days. During that time, you're on an antibiotic to prevent an infection. You're on estrogen to try and get that lining to quickly develop across that raw surface. And then after a few days, the catheter is removed. After a few weeks, we check the healing. It takes about 3 months for the inflammation to resolve and the cavity to completely heal so that then you're ready to try and conceive. All right, so another uterine condition I treat is called Asherman syndrome. Dr. Asherman described this a long time ago. he characterized women who had an episode of postpartum hemorrhage. In that instance, the woman is bleeding profusely. And a lot of times it's due to retained placental tissue, and a D&C is performed, and sometimes that D&C is very vigorous. In the immediate postpartum time, the woman is in a low estrogen state. And when a vigorous D&C is performed, it can cause, in that hypoestrogenic state, for those raw surfaces to stick together. And in that case where the walls have stuck together, a lot of times it will result in no periods or very light periods and the inability to conceive. And then what happens is if you go in and you remove that scar tissue and the uterus heals, then the woman has a much better chance to get pregnant. So we go in and we identify what the scar tissue is, where it is, and how the cavity is distorted, and we try and reconstruct a normal triangular uterine cavity. And once we're done, we can see that we've made the cavity look like that triangle it's supposed to. Once we're done, we put a catheter with a balloon in to kind of hold the walls apart and treat the woman with high-dose estrogen to grow lining over those areas that were previously adherent to each other, so that we let the uterus heal, get that estrogen to build that lining all up through that cavity so it's back to normal. So I see a lot of women with fibroid tumors. Fibroids are extremely common. 70 to 80% of women have fibroid tumors by the time they're 50. They are muscle tumors. They grow quite large. If they are growing into the uterine cavity, they can cause heavy bleeding, painful cramps, and we know that fibroids that distort the uterine cavity cause a lower implantation rate. So if you're going to invest all the time and energy in vitro fertilization, you want the best opportunity to conceive. And I remove them either transcervically through hysteroscopy or with laparoscopy instead of open abdominal surgery. And then the new technology that I can offer is called radiofrequency ablation. So for those small fibroids and very hard to reach places, this is a way of addressing those also. Large fibroids that cause symptoms such as bladder compression, literally make you look pregnant. We know those are likely to affect anatomic function as well. And rather than a big incision that puts you out of work for 6 weeks and is pretty painful, I can use a pencil-sized scope and 4 ports where 3 of them are the size of a pencil, and your biggest incision is for a 1/2 inch access port. Even large fibroids, 10 and 12 centimeters, can be removed with that technology. The difference is it's an outpatient procedure. You're back to work in 10 days. Some of my patients actually are back at their office in 4 days if they just work at a desk. So it's great to be able to offer these less invasive, less painful procedures and then help women to conceive. Now, when we take out fibroids, it's very important that a woman wait long enough before trying to conceive so that the uterus heals. And the current recommendations are to wait 3 months after the surgery for an embryo transfer or to try and conceive. If your period starts 2.5 months after your surgery, you can try and conceive that cycle. But we just want to make sure that everybody is healed well enough so that they don't take any chances. Now, some fibroids are fairly superficial, or the ones that are inside the uterus. We take those out and a woman can deliver vaginally, but if it's a large fibroid, especially if it's deep, those patients are going to need a cesarean section for delivery. We don't want to take a chance that during labor the uterus would not hold up and might tear, and that could be disastrous. So many OBs will want to do C-sections, especially for the large, deeper fibroids. So I treat endometriosis. One of the most effective way to treat endometriosis is excisional therapy. We know endometriosis impacts the implantation rate. Removing the endometriosis makes the uterine cavity more receptive to implantation. So when a woman is referred for endometriosis, I do excisional therapy. That has been shown to be the most effective at pain relief. And in the long run, if you're going to do it, you want the best outcome. I also feel very comfortable treating advanced stage endometriosis, stage 3 and 4 disease. Patients will come in, their rectum is stuck to their uterus, their ovary is stuck to their pelvic sidewall. In the middle of all that inflamed mass of endometriosis is their ureter, the tube that drains the kidney to the bladder. So you have to be able to dissect the ureter out of the endometriosis without injuring it. And I do quite a few of those surgeries, several a month. So, I treat the endometriosis very comprehensively. Some of these surgeries can be 3 and 4 hours, and I always give my very best effort to every patient for their endometriosis. So ovarian cysts are also another problem that women have. Dermoid cysts, other what we call neoplasias. So in the infertility literature, doctors are advised not to stimulate the ovaries when there's a cyst of unknown origin. So when a woman presents with an ovarian cyst, the ovarian cyst needs to be removed so the doctor can safely stimulate the ovaries. I rarely open an abdomen for an ovarian cyst because I'm very comfortable removing the cyst laparoscopically, and then I suture the ovary closed once I've removed the ovarian cyst. And indeed, there's less damage to the ovary if you suture the cyst closed. There's also likely to be less postoperative bleeding because when you suture the cyst closed, you've stopped the bleeding. I still wrap the ovaries with the adhesion prevention material, but everything I do is to address the ovarian cyst just like I learned to do it in the open operation. When the doctor does an open ovarian cyst, they always suture the ovary closed, but laparoscopically, most doctors, because they don't know how to suture laparoscopically, they will just cauterize the bleeders, which unfortunately is more distressing to the ovary. And then bleeding from the ovarian cyst area will likely result in adhesion. So now the tube and or the ovary may be stuck together in such a way that it lessens the chances for pregnancy. And everything I do is designed to optimize the pelvic anatomy so that the woman has her very best chance to get pregnant.